Great. Looks like we're online. Good evening, everyone. My name is Dr. James Zhang, and I'm here to host the Primary Care Cancer Control QI Toolkit launch. It's a very exciting project, hoping to further increase our screening numbers and also get involved with new tech platforms. It will be a very exciting night, and with this, there's going to be a little bit of interaction as well. If you're logging in and you're seeing the slides, can I encourage you to use the QR code on screen to join ahaslides.com/NSCR2022. You can log in on your browser or you can use your phone, whichever works, but it's all just a little bit of interaction just to get us going. And hopefully we'll be trialing this for future webinars as well. Just to start with, as always, we at the CESPHN acknowledge the Aboriginal and Torres Strait Islander peoples of this nation. We acknowledge the traditional custodians and sovereign people of the land across which we work. We recognize their continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. Bit of housekeeping tonight. We'll have a Q&A, which you'll be using in the Zoom panel. So there should be a Q&A little icon at the bottom of your Zoom screen. So if you do have any questions, feel free to send it through to that, and we'll have a Q&A at the end, which will with our panel.
2022.
All right. As a reminder, at CESPHN, we are hoping to refine what we do with our CPD program and on ways we can use, to make things qualitative use of your time. So if you were to enter your contact details at the end of the survey using the QR code, you will be able to enter the draw to win one of 4 $50 prepaid Visa cards. So while everyone is logging in, just to try out the platform, just to add in, where are you logging in from tonight? So if you are using the platform, you should hopefully be able to see a prompt and you should be able to type some things in. Sydney. SWS, welcome. From Campbelltown City, Bowel, Maine. I'll give about maybe 10 more seconds. Inner West Sydney, Dubbo. Wow, Dubbo, good on you. Forest Reefs. I'm simply amazed by the demographics. For me, I always thought the CESPHN webinars would just be contained within CESPHN. So it's really awesome to see a mix of people in different areas. But all right, that was just kind of a simple question just to get us going with making sure the platform works. Now, hopefully you'll now see some survey questions to just get you thinking about cancer screening in general. And you'll be able to slide across from strongly disagree to strongly agree. But 4 different questions. The first one being, I routinely discuss cancer screening with patients in my consults. I know where to seek information about cancer screening in a timely manner. My practice engages with QI on cancer screening, and I am confident on installing widgets/programs onto my practice platforms. So we'll just see some answers coming in. What happened to red? There we go. So routinely discuss cancer screening with patients in consults. Mostly strongly agree. Solid work, everyone. And hopefully this night will then hopefully refine a bit more on how we can make your time more efficient in that process. Knowing where to seek information about cancer screening in a timely manner, still on the agree side, but maybe a little bit more in the middle. And that's good. Hopefully John will be able to talk a bit more about that tonight as well. My practice engages with QI on cancer screening, a little bit on the less side, and that's okay. That's why you're here. Dana will be able to talk a bit more about how that may look in a practice from a practice perspective. And I suppose the last question was more my own personal curiosity, a bit more of a techie myself. I'm confident installing widgets and programs onto practice platform, maybe on the lower side as well, but that's okay. The CESPHN is designed to help people adopt new technologies and help smooth out the processes as well. So thanks everyone for your input. And again, just a bit some introductions. We'll have 3 speakers tonight, each going for 15 minutes. Our first speaker will be Ms. Tracy Wills-Bashista from the Cancer Institute, New South Wales, and she'll be talking about introducing the Primary Care Cancer Control QI Toolkit and a bit about the screening information behind that. Then we'll have Mr. John Lee from Telstra Health talking about the National Cancer Screening Register and how we can access that to bowel and cancer screening data. And then we have Dana C, practice manager from Campsie Medical Practice, on the patient journey to bowel cancer screening in the primary care setting. After that, we'll hopefully have a bit of Q&A, and then we'll be able to call it an evening after that. So with that, I leave it to Tracy.
Sorry. Thank you, James. Can you hear me there?
We can hear you, Tracy.
We can hear you loud and clear.
Oh, sorry. Okay. Hi, everyone. Sorry about that. So I'm Tracy. I'm from the Cancer Institute, and I work in the primary care team there. And my colleagues, Donna and Mary, are also online tonight. And the work of our team is guided by a framework. So it outlines the importance of working with primary healthcare to support and engage primary healthcare across that cancer continuum. So we know the important role you play, but our talk tonight is mainly focused on cancer and cancer screening and prevention. Firstly, I'll start by acknowledging the traditional custodians of the lands as well, that we work and live, and recognise their continuing connection to land, water and community. And I pay my respects to elders past and present, and I'm calling from the Cammeraygal lands, which is also where the Cancer Institute is located, next to Royal North Shore Hospital. So I'll just start by saying why we're here. So in 2009, we developed a cancer control toolkit following an evaluation of some primary care grants. And we've now revised that toolkit. So it's online, it's more easy to use, and we have 4 modules within that toolkit. So 3 of the screening modules, which we'll talk to a little bit tonight. And then we have 1 prevention module, which is the smoking module, and we have a few more in the pipeline on alcohol and skin cancer. So firstly, I'll take you through some of our report charts from the Reporting for Better Cancer Outcomes reports, which we do at the Cancer Institute, and then I'll introduce you to the toolkit after that. So firstly, the Cancer Institute is a state government agency, so it was established in 2003, and our vision is to end cancers as we know them. And I've just put the Ministry of Health framework there for you to see where we sit. So we're one of the pillars on the right there, and in purple. And so we're guided by the New South Wales Cancer Plan. So we're working to achieve equitable cancer outcomes, reduce the risk of preventable cancers, increase 1 and 5 year survival, and improve services through the collection of patient experience and outcomes. At the bottom, we have the 3 national screening programs, and I'll talk a little bit more about that as I go through some of the charts. So now I'm going to start with the bowel cancer participation rate. So this is all from the Central Eastern Sydney PHN ROBCO report, and the data source is the National Cancer Screening Register. So the ROBCO reports are based on indicators along the optimal cancer pathways, and they show the variation across settings from that indicator. So the first chart that we have here is showing the participation rate for bowel cancer screening, and I have taken the other PHNs out just because there's a lot of permissions and data governance around all the different reports, but it's showing that it ranges from 42% at the top down to 30% at the bottom, which is where Central Eastern Sydney PHN region sits. And we know that we need to improve this across all PHNs. So secondly, we have the annual cancer screening kits return. So we can see over time what's happening, and that as we send out more invitations, there are more kits returned, but that we need to do more than that. And you can see in 2020 there is a reduction in screening, and that's the case across all of our screening programs. Okay. Oh. Sorry. It's a touchy screen. Okay, and so onto the next chart, we have bowel cancer screening rates and diagnosis. So this is from the incidence and mortality data set, the New South Wales Cancer Registry. So the first chart showing the extent of disease at diagnosis, and you can see the highest degree of spread notified to the registry within 4 months of diagnosis. We can see that's at 33% localised and 60% are regional or distant, and it's just giving a clear picture of the need to increase that localised proportion. It's important to note here that we're talking about all patients with bowel cancer, not just screening patients, but also symptomatic patients presenting. So it's a different population group. And then secondly, we have a chart, and this is not my slide, but it was some modelling done by the Daffodil Centre, which is Cancer Council New South Wales and Sydney Uni partnership. And it's an unpublished paper, but it's showing that screening is working. So with no screening, we would have deaths at 52 per week. Where we are now is 37%, or I think it's 41%, and we've got 39 deaths per week. And if we were screening at 60% participation rate across New South Wales, we could reduce that down to 34 deaths per week. And then nationally, if we could have that rate at 60%, they think that we could prevent 90,000 cases over the next 40 years. So I'm just going on to the next screen there. So then on to breast cancer. So the data source for this is the Australian Institute of Health and Welfare and Breast Screen New South Wales. So I'm just showing again the participation rate for women. So we can see that it's ranging from 55 up the top down to 42%, and Central Eastern Sydney is sitting at 45.5%. So still 50% of women aged 50 to 74 in New South Wales are not being screened. And over time, there isn't a huge change in those eligible versus those participating, but again, a decrease in 2020 due to all the lockdowns that happened and breast screen being shut. And then lastly, we have the extent of disease at diagnosis, and 52% of women having localised disease within that first 4 months. So some key points here is that most women, it's the most common cancer affecting women. 1 in 7 women will develop breast cancer in their lifetime. And Breast Screen Australia was introduced in 1991, and there has been a steady decline in mortality rates from breast cancer for women aged 50 to 69. So we know that women who screen regularly are more likely to be diagnosed with localised disease. They're more likely to have breast cancer, breast conserving surgery. They're half as likely to require a mastectomy and less likely to need chemotherapy compared with lapsed screeners and women who have never screened. Okay, so moving on to our next slide. So onto cervical cancer, and the data source here is the Australian Institute of Health and Welfare. And we have some preliminary estimates because we don't actually have that full 5-year of data for the new 5-year program. So the first chart is showing that participation rate and how it varies. So you can see at the top, so we've got 50% down to 39% across the PHN regions, and Central Eastern Sydney is sitting in the centre there at 44%. On the second chart, we can see how it changes over time, with age, and that increases after 44 and then decreasing after 60 years. And I'll just go on to our next page. So here, I just wanted to show you the GP recording of cervical screening for the last 5 years. So Central Eastern Sydney's at 36%, again, ranging from 45 up the top down to 21 at the bottom across the PHN regions. And the data source is the Practice Incentives Program QI measures. And then we have, again, the extent of disease at diagnosis, so at 49% for localised disease. So some key points is that the national cervical screening program started in 1991, and both incidence mortality have fallen by half since then. And with the HPV vaccination, the 5-yearly cervical screening test, and recent changes with self-collection, we have the potential to be the first country to eliminate cervical cancer by the mid-2030s. And that lastly, that 80% of cervical cancers occur in women who have never screened or are not up to date with cervical screening. And like the other cancers that we've gone through tonight, earlier diagnosis results in improved cancer outcomes. So I'll just go on to the next cancer. So what can we do? We have our toolkit, and the toolkit's asking us to stop and look at our practice population. What's the overall picture? What preventive activities your practice team or practice population are likely to be receptive to? In terms of what you do, where are the gaps? What are your priorities? And instead of assuming that we do things well, just looking at the data and working out ways that we can improve. So we have some points here. So understanding who are your priority populations for cancer screening and cancer prevention activities, and working with your whole practice on the QI activities. So we can improve your data capabilities, and you can reach out to your PHN for support around that. We can embed prompts into your systems and health assessments and ask these questions. And we can remind patients through digital promotion and practice resources or waiting room posters. And lastly, we can compare this quarterly and also claim the PIP-QI incentives. So on to this. So this is online, the actual toolkit, and this is some pictures of what it looks like on the opening page. And then we have these accordions where you can actually click on and open more information. So please share any feedback on the toolkit because it's constantly evolving and we need to make sure that it's meeting your needs. So it's an online toolkit, and through feedback, we knew that the previous version was quite big and hard to navigate. So we've changed that. So it's got a consistent look and feel. It's got those 4 key elements that sit across each module. So patient-centered care, team approach, data and systems, and then the quality improvement activities. And it's broken down into manageable steps that your practice can take that will save you time. So you can go directly to the specific module that you're interested in, choose your area of focus and find that key information there through the drop downs. And you can open as much or as little information as you need. So then just on to some other key resources within the toolkit. We have our quick reference guide, and these are available for each module. So you can read through those readiness checklists on the right there and see what you need to focus on. And we also have some models for improvement in PDSA cycles and some example activities of what you might work on. So performing a data cleanup with clinical software, marking patients as inactive, deleting or updating all reminders and recalls, creating a defined list of codes so you can easily pull out the information and analyse it, integrating with NCSR, which John will go through that. You can involve more of the practice and plan and run a cervical screening clinic. And you can create a supportive environment that encourages people through promotional information in the waiting room and treatment room and get resources. We also have a resources tab where you can get all the key resources across all the modules rather than going through them if you found something of interest. Some other key resources that we wanted to highlight for improving screening rates. So there's data extraction tools on how to filter and look at your data in terms of who's under screened, never screened or overdue. And you put in the numerator and denominator of those eligible versus those screened, and you can pull that out. So that's the PanCat example there. And then there's, I'm just including the red book and the green book so you can refresh your knowledge on preventive care and how to implement preventive care in general practice. And then that's it. So thank you. And also just wanted to share our website and toolkit link, and there's an email there And any questions? I'm sorry for that, for those mishaps at the beginning.
Great. Thanks so much, Tracy. Yeah, evidently we see a need for greater screening and greater data capture, especially within our PHN, based on the information that we see here. I would now like to invite Mr. John Lee from Telstra Health to introduce us to the NCSCR and digital access to participant bowel and cervical screening data. Take it away, John.
Awesome. Thanks, James. And hello, everybody, and thank you so much for the team for inviting me to present to you all today. Now, I'm actually down in Chile, Nam. It's freezing today, so I'd like to begin by acknowledging the traditional custodians of the land that I am presenting from today, being the Wurundjeri people of the Kulin Nation, and I pay my respects to elders past, present, and emerging, and extend that to all lands across Australia. So I'm going to talk to you a little bit about digital access to participant bowel and cervical screening data, which is held on the National Cancer Screening Register. And just a quick intro to the register. The NCSR is a digital platform that was developed to underpin both the cervical and bowel screening programs. So it's designed to support the end-to-end operations of the programs to help achieve that shared goal, which Tracy touched on, of eliminating cervical cancer by 2035 and saving over 80,000 lives from bowel cancer by 2040, if we can increase the participation rate to 60%. So the National Register has been supporting the cervical program since renewal of the cervical program, so 1 December 2017, and has been supporting the bowel program since November 2019. So that brings together those, that's an individual screening record into that one central record. So what does the register actually do? So it's not a repository like a cancer register. The NCSR manages all operations of the programs. So we integrated with the Medicare database, so we can invite and remind eligible people for screening when they come due. We receive the laboratory test results and also histo, as well as CST and the bowel test kit results. And then that data is ingested into the participant's record, and the clinical algorithm is designed to place the participant on the correct pathway based on the clinical guidelines. And then the participant is invited and reminding as appropriate after that. So the register also enables or facilitates follow-up of patients. So GPs, people working in primary care, can access their patients' screening history and understand what steps to take next. And we also have some follow-up officers within the register that follow up participants and the healthcare providers if that person hasn't taken the next step on their pathway. And that's kind of like the safety net of the register for the screening programs. For the bowel program, those follow-up officers sit within the jurisdictions and they perform that function using registered data. And then all of that data is used by AHW and federal and jurisdictional governments to improve the programs essentially and check in on the screening policy and see if there need to be any tweaks along the way. So the core pillars of the register and its purpose is really to maximize participation by inviting and reminding eligible people, facilitating timely diagnosis of screen detected abnormalities. There's a big focus on informing continuous improvement by evaluation and safety monitoring of the programs using data and reporting. And what we're going to concentrate on in this session is a focus on creating that connected ecosystem so that all people involved in a patient or participant's screening journey can access the information at a time convenient for them. So in terms of creating that connected ecosystem, we released functionality available through PRODA a couple of years ago, and that's the healthcare provider portal. And this provides GPs, practice staff, with access to their patient screening information. And we've also integrated, as I'm sure some of you are aware, with best practice, medical director, and Communicare. So that screening data is available directly within a patient record within your systems, rather than having to log into Proda and search for the participant or patient in these terms. So we've seen some really good feedback coming through from users, mostly focused on the time that the portal is saving them, particularly for access to downloadable PDF screening histories for the cervical program. And of course, the ability to order bowel kit, a bowel screening test kit directly to their patient's address, which is a function of the portal and the integrations with those systems as well. So there is a registration process to go through, and I'll touch at that on that towards the end, but we've got some support in there if anyone is struggling with that registration process for the integration of those clinical information systems. So we'll take a quick look at the functionality that's available in the portal and through the integrated system. So you can access your patient's bowel and cervical screening results and histories online. And within the participant record, there's also the next screening action, which is viewable as soon as you access that record. You can submit program forms electronically. So for example, a GP assessment form for the bowel program can be submitted in real time to the register to be ingested into that participant's cancer screening record. You manage patients' details and preferences. So if in your local record, or you've got the patient in front of you and they tell you they have a new address and the address is different on the register, you can update that for screening correspondence. And as I mentioned, you can order replacement bowel screening test kits. So if there's if there's somebody in front of you in practice and you've touched on bowel cancer screening, and they've maybe said that they know the kit is expired, or they've thrown it away, but then after speaking to you, they've now decided to screen. You can just go into the system, click on order a replacement kit, and that will go directly to their address. So I mentioned the healthcare provider portal is accessible via Proda, and the integrated clinical software with best practice medical director means this functionality is available in the patient record, but there is still a one-off registration process that you would go through within Proda to register your HPIO, and that's essentially because we're dealing with very sensitive private healthcare information. So we need to make sure that your details for the practice are recorded in there so we know where that data is going to. And now I am going to click to the next slide to play a video, but it seems I can't play sound from my video unless I unshare and reshare. So just bear with me for 1 second. I'm now going to go through a demonstration of the healthcare provider portal, and I'd just like to state that all data you see today is test data only, and there are no real patient or healthcare provider details contained within this demonstration environment. Healthcare providers access the NCSR Healthcare Provider Portal by logging into their Proda account, and Proda stands for Provider Digital Access, and it's an online identity verification and authentication system which is used to enable secure access to government online services. We can use several participant identifiers to find the exact match for our patient, Anna, including Anna's Medicare number, register reference number, individual health identifier number, or Department of Veterans Affairs number. And below we can see the matched participant and select either the bowel or cervical record. We can see Anna's demographic information on the home screen and that Anna is eligible for both the cervical and bowel programs. We're currently viewing the cervical record and can see that for Anna, there is a recommendation to refer for colposcopy and an alert that indicates higher risk and a diagnosis of HSIL. We can access the live screening history by clicking here to gain more information on the participant's screening journey to date. So on this downloadable PDF, we can see Anna is HPV 16/18 positive with a high-grade squamous lesion suggested on cytology. which means Anna has a precancerous abnormality. So the recommendation here is to refer for colposcopy, which can now be completed by the GP in the practice system. So once Anna has been referred for colposcopy, Anna's colposcopist can enter data from the procedure into the colposcopy data collection form directly into Anna's screening record. So in the interest of time, I won't go through the form now, but essentially, once a form has been submitted, the next screening action is updated in real time, indicating that the colposcopy result has now re-triggered Anna's cervical screening pathway. So if we move over to the Bowel program, Anna's GP can see that Anna is yet to complete a fecal occult blood test kit. Anna's GP can then order a kit to be sent directly to Anna's address for her to complete at home. So while we're in the patient record, we can review the demographic details for Anna. And these details are taken from the Medicare database. And with the patient's consent, we can update them to be changed for screening program correspondence. We can also update country of origin and indigenous status details, as well as updating the nominated provider for Anna. So the healthcare provider can also view any correspondence sent to either themselves or their patient from the register as well. As many healthcare providers rely on their support staff to collect information ahead of busy clinics, there's the option for healthcare providers to provide delegation so their support staff can also access the portal on their behalf. And delegation can be approved or denied through the Manage Delegation tab. And I'm back. Sorry about that. I just had to reshare my screen. That gives you an overview of all of the functionality in the healthcare provider portal. But I just want to reiterate again that functionality is all available within the integrated system. So if you have Best Practice Medical Director or Communicare, you've got access to all of the same information and the same forms. It's just directly within a patient record. So for example, with Medical Director, it's contained as a widget in the sidebar. And we're fortunate enough today that Dana is also going to show us an example of this functionality in best practice. But just a quick look at how this looks in Communicare. So again, this is test data only. It's not a real person. And when you're in the Communicare system, you can click on the NCSR hub, and when you're in the patient record, and it brings up the NCSR information here. So there's forms available, the screening histories, and the ability to look at the screening status and update a participant's registered details. Now, there are a number of support materials at ncsr.gov.au. There's a few videos similar to the one that you've just seen. And user guides as well. And there's further information about how to register to integrate with your clinical information system. Now, in the interest of time, we won't go through how to register through PRODA, but in terms of gaining support, if you have tried to do that and have struggled, one of the best things to do in this regard is to click on this link, which I will share in the Q&A, and you can speak to one of our digital specialists so they can walk you through everything that you need to do within PRODA to register your HPIO and support you along the way. And in terms of usage, we now have almost 13,000 healthcare providers and their delegates accessing the healthcare provider portal. And I mentioned delegates because, as it noted in the video, a practice manager or support staff within general practice can also access patient details within the portal if they request to be the delegate of one of the GPs or somebody within the practice that has a Medicare provider number and is also registered on the portal. Now, it's much easier in the integrated integrated systems, because registering the HPIO and having a responsible officer registered at the NCSR means that anyone within the practice can access the NCSR data within a patient's record in the system. So we're increasing numbers quite rapidly, and the number of practices that have integrated, and we've got 1,744 registered so far. Now we don't know exactly, but they're estimated that there's around 7,000 plus practices in all of Australia. So we've got a bit of a way to go, but we're hoping that you can assist us with that. And in terms of a couple of stats there, one of the benefits for accessing cervical screening histories online that we've seen is that people are really liking it because they've stopped faxing us. We used to get about 8,000 faxed screening history requests every month, and now that's down to about 240. So we can see the benefits there, and I will leave it there. Thanks, James.
Thank you so much, John. And speaking as a GP who's using the platform and widget on Medical Director, I cannot tell you how much time I have saved when you're in the situation where you ask a patient, so when was the last time you had a cervical screen? Oh, okay, well, I can actually access it on the widget, a few clicks. Oh, I know when your last CST was. Oh, I can see that you're overdue for a bowel cancer screen. Let me order one for you. It's just so much easier. So it's a fantastic platform. And I'm now going to introduce Ms. Dana C. To give us a journey on bowel cancer screening in the primary care setting. So a bit more on the practicality of what that may look like on a day-to-day. Take it away.
Thank you, James. Thank you, John. Can everyone hear me okay?
Yes, we can.
Yep, loud and clear.
Great, wonderful. So I have the wonderful opportunity to share a patient's journey through a general practice. In particular, once you have got NCSR linked in with your clinical software. And in this scenario, we use best practice. So Eric is a 52-year-old male who's come in to see our GP. In our practice, it's standard that a nurse will see the patient first. And when she opens up Eric's clinical file, she can see from that centre that the NCSR bowel screening says that Eric is overdue for his screening. When you go into view and then the NCSR hub of the clinical file, we get more information similar to what John had shared before about where they are in their screening journey. So here we see that Eric is overdue for screening and he's never had a screen since he turned 50. So our practice nurse will then get out the kit and ask Eric, have you received this home test kit? These are the instructions and this is what you're supposed to do. And we find out that Eric hasn't actually received a kit. So the nurse goes back to the NCSR forms and she's able to lodge a form online to get a replacement kit for Eric. Eric goes away, he does the tests, and within the GP's inbox, we can see that Eric here has a positive FOBT that's come back. And so the GP has asked Eric to come back and to be recalled for an appointment. In that appointment, the GP is able to explain the result and the next steps. And rather than having the paper form, which you fill out, you scan, you fax, and you put back into the software, this can all be done online. So it saves time, and you can also save it as a PDF within the patient's file. So just like the paper form, the demographics of the patient can be filled out, the symptoms if they're known, and the assessment outcome for the patient if they are referred for colonoscopy, as well as the specialist that the GP has referred them to. So now on to some troubleshooting tips. It would be wonderful to firstly integrate the NCSR with your clinical software and to educate your nurses and doctors where to check and what to check for in the red reminders. It would be fantastic to include screening for cervical, bowel and breast screening into daily practice, and making it part of your workflow within the practice. It's also wonderful to be able to track your progress through a QI activity, to see the data of how you're progressing in your journey, to make preventative care part of general practice. You don't need to reinvent the wheel, so best practice has a number of supplied queries that you can use to go through your data, to clean your data, as Tracy mentioned before. And some great starters is the Cancer Institute resources, as well as the NPS MedicineWise learning portal, which has a lot of extra information on cancer screening. So thank you for your time. If you wanted to share what you've been doing or wanted to get some help, I'm more than happy to take questions and for you to contact me after the presentation. So thank you.
Great. Thanks so much, Dana. So we come now to a time where we have some Q&A. So if people have any burning questions about how the NSCR works or how that may look in your practice, feel free to use the Q&A function in the Zoom panel button below. Click and type your questions and we'll aim to try and facilitate them. One question that I know that we talked about earlier, and I'll direct this one to John, if he's there, is for us as GPs, obviously we know that we're aware of cervical cancer screening and breast cancer, and bowel cancer screening. Why is it that we don't have any breast cancer screening on this platform?
Good question, James. So although these are all government programs and they're all titled cancer screening programs, as I'm sure you're all aware, each cancer screening program operates very differently. So with the bowel screening, you get issued a test kit to your home. The test kit gets sent off to Sonic. They process the results, and the patient gets a letter as well as the nominated provider. With cervical screening, I don't need to explain that. You all know how it works. But with breast, because you are going for a mammogram, either a private or a public radiology provider, the program works slightly differently. So the program's managed within each jurisdiction for the breast screening program. So the breast screening program manages the register, all the data that is held, but also all of the appointments, bookings, up to the clinical assessment, and also manages all the contracts with those radiology providers, including the regional assessment centers. So it's quite a different operating model for the breast screening program, and the breast screening data isn't contained on the National Cancer Screening Register.
We have another question. This might be more for Dana. Can I hold the bowel kits for patients who are homeless?
I wouldn't know how to answer that. Sorry, James. That's a really great question. Maybe John would have some understanding.
So the bowel test kits are sent to the person's Medicare address. So in order to get that result back to that person, it would need to go to the registered address on Medicare. So I think explaining to a patient that maybe has no fixed abode, that's the process. Perhaps they can organize for an up-to-date address, or perhaps a friend's address to be their Medicare address.
And so to, I guess, follow on with another question in the Q&A, can a non-Medicare patient have an NCSR profile?
Non-Medicare patient. So each patient record has a national identifier, and there are 4 identifiers that we can use. So it doesn't have to be a Medicare number as an identifier to, say, search for a patient record in the NCSR. So it can also be the Department of Veteran Affairs number, the register retrieval number, and the IHI number as well. So not necessarily a Medicare number. Now, if we receive results from a lab and the Medicare, we've contacted the lab and we can't access a Medicare number, if we cannot match that to an existing record because of other identifiers, like what we call a fuzzy match, then that may create a duplicate record within the register. That's not possible, but that they will have a record.
I feel like a lot of the questions are very much data driven, John, so you're probably getting bombarded tonight. But how is data collected from the patient? Is it every 6 months or early? Not sure.
In terms of the details in the person's National Cancer Screening Register record, we get a regular feed from Medicare. So if somebody changes their Medicare address, we are notified by Medicare and can make sure that we have the most contemporary address. And of course, other details that are recorded in Medicare around the demographics. If that doesn't answer the question though, please do write back in.
Question for Dana. They're having a lot of issues loading forms when using breast prac, both as a nurse and a GP. Is this a tech issue or a registration prod issue? Perhaps maybe more to springboard. Have there been any issues for you when you were utilizing this platform at the start, or how did you seek to overcome that?
Occasionally you might get some outages to the NCSR link, but so far we've had a pretty smooth ride to submitting things online. So possibly, Rebecca, it'd be good to get in touch with the PHN to troubleshoot those issues to find out whether they're best practice, whether they're NCSR or something else.
I'd also recommend giving us a call as well. If there is an issue with one of the integrations or the portal, it's really, really important that we know about it, just so that we can make sure that there's nothing wrong on our end, and if there is, then we can put a fix in place. And if this is just a once-off issue with one practice and we're not aware of any issues and we can't see any issues within the system, be good to give best practice a call and see if they're having any local issues at their end as well.
Right. Thanks so much for all the questions. Are there any other questions that people want to ask? While we're waiting, I may as well just do a few other little announcements. So if you have any other questions, feel free to answer. But just as a bit of a reminder for everyone, just on a few other things that are happening within the PHN. We know that COVID is becoming more of an issue once more. And just a reminder that there are COVID-19 information and resources available on the PHN, as well as on the New South Wales Health website and the Department of Health. And if there are any questions regarding the management of COVID, or if you need practice support with getting equipment and PPE, or if there's general immunization inquiries, there are various emails and links that one can access in this time. Also a reminder that I guess linked to what we're talking about tonight with cancer screening is that GPs and practices can access the GP Cancer Support Line and GP CanShare. So that's a 1-800 number where you can access provided care for specialist cancer and cancer-related palliative care advice. And they're open Monday to Friday from 8 to 6. And the GP CanShare, whether it's linked with a cancer CNC, may help with just guiding which hospital, which cancer center to refer to, as well as what other services may be available for your patients. So just a reminder that there are additional things beyond the screening, but also for the care of patients with cancer. Also a reminder that a copy of the slides with useful links and resources will be emailed out to all attendees tonight. So if there was anything that was missed out on, or you couldn't access the link from because it's on a slide format, you should hopefully be able to access some useful links after the presentation tonight. But with that, on the assumption that I don't think there's any other questions, I think we will close this as an evening. And thank you once again for your attendance, and we hope to see you in the next webinar.
Thanks, James.